Well, thank you so much for inviting me. I moved to Washington about 3.5 years ago from Alabama. And when I did my fellowship in Boston, although I did my training in Cincinnati, I was first introduced to kids with lead poisoning. I'm like, lead poisoning? Well, then I moved to Boston and had the first part of my career in New England, and just about every child had an elevated lead level. And then when I moved to Alabama, I didn't think I'd see lead poisoning, but oh, it's there. And then I moved to Washington State and didn't think I would see much lead poisoning. And when I was interviewing for my job here in April of 2016, one of the top stories on the news as I was getting ready for my interview was about lead poisoning in children. So it's been a very interesting journey. And so I'm going to put my lead poisoning hat on, because I think it's a very, very important public health model of prevention and how we as pediatricians can prevent this poisoning. It is a poisoning, and it's probably the #1 environmental poison that we have the most conclusive evidence about its adverse effects on children, on the developing brain, as well as pregnant females, and its effect on the fetus. I did receive funding from Public Health Seattle King County to develop this presentation through their CDC lead grant. The Poison Center actually has a grant with King County to do community outreach and teaching on lead poisoning in King County. So this funding, I received some of the funding through the Poison Center, and I developed this talk. So the objectives today are to understand risk factors for lead exposure in children, including sources of lead, to understand the adverse health effects and toxicity of lead in children, and to describe Washington State focused lead screening guidelines and reporting. These are some of the abbreviations you'll see in my slides, which I believe will be posted and certainly can be used by anybody. With the elevated blood lead level, my definition, and we'll talk about this, greater than or equal to 5 micrograms per deciliter. So these are 3 scenarios, and I used to go to lead clinic in Boston as part of my fellowship every Monday morning for 3 years. And again, I had some lead consultations in Alabama. I was their state consultant. And we get calls at the Poison Center about lead too, but I'm also going to tell you about a lot of other great resources that we have in Seattle I'm so grateful for, with the Pediatric Environmental Health Specialty Unit at UW, and this is falling off of me. Okay. So, 1-year-old presents for well child care. You do a capillary blood lead level, and it's 8 micrograms per deciliter. So what do you do with that? Case 2, a 2-year-old presents for well child care, and as part of your screening, you do a capillary blood lead level, and it's 90 micrograms per deciliter on your point of care machine, or wherever you, however you assess that. But the child is asymptomatic, no concerns. And then you have a very different scenario. A 4-year-old with autism presents with abdominal pain and constipation, and mother reports that he is eating the banister in their 100-year-old house. Venous blood lead level is 72 micrograms per deciliter, and that's his x-ray, which shows paint chips throughout his abdomen all the way down to his rectum. What do you do? Actually, the last scenario, in my opinion, is probably the easiest scenario in terms of what do you do. And the first 2 scenarios, I think, are certainly the most common ones that general pediatricians face. And so we're going to talk about this. So a few basic facts about childhood lead poisoning. Lead is an environmental toxin that has really conclusive and extensive scientific evidence about its human toxicity. There are other environmental toxicants, in my opinion, where we are just starting to see the emergence of really conclusive scientific evidence about human toxicity, and especially in children. But I think lead and mercury, in my opinion, are the two that we have the most. I think we all know, for all of us that are pediatricians and see children, that children's developing brains are vulnerable to lead's toxic effects. We have a lot of animal studies going way, way, way back, as well as studies from the 60s and 70s, 80s, and all recently up until now about the vulnerability of children's developing brains. And actually, when I was a fellow, I remember being taught that, well, the brain probably stops developing around 6, and so why are we worried about adults with lead poisoning? Well, that whole thinking has changed with the emergence of evidence, saying that there is still ongoing development, probably up until the age of 24 or 25. And I think healthcare providers play an integral role in the primary and secondary prevention of lead exposure and its potential adverse effects in children. So the old sources, and I put old in quotation marks because we still have these sources. They didn't go away, okay? Lead and paint, number one, number one, number one. And this is a great advertisement from the 60s about, you know, Dutch boy paints. And why did they put lead in paint? To make it last, all right? And so it wouldn't chip. But we know that lead was actually taken out of household paint in 1978, and so homes built before then, where are the sources? How were kids and other people getting exposed? The deteriorating paint, and that's certainly what we saw in the housing stock in New England, where homes are 250 years old and well, maybe not that old, but 200 years old. But we have old housing stock here, and we'll talk about that. But paint chips, dust from renovations, you know, the whole household rehab craze, very, very interesting when you look at the epidemiology of lead exposure in children. And where do little kids get into this? In the windowsills, when you're opening and closing. What I found when I moved to Washington, a lot of houses don't have air conditioning, and so I said, where's the air conditioning? When I was looking at my house, and they're like, we don't need air conditioning here. You open your windows, and now I understand that, because it's very, very nice about 3 weeks out of the summer. So, but you know, when you live in the deep South, you don't open your windows, okay? Because you get the bugs and the roaches, and it's too hot. But people, you know, still there's chipping and peeling paint, door frames, windows, etc. Other old lead sources, gasoline, it's out of the gasoline we use. That was taken out a long time ago. But if you go to countries like Asia, India, it's still in gasoline in cars. Drinking water, I'm going to talk about this in a minute. But again, the soil, so housing stock that has been torn down in the soil. The kids play outside, there's not grass cover. They bring it in doors along with the dust in the windows. Very normal oral to mouth behavior in kids. You know, that's where we see, again, the primary etiology, depending on where children live, and we'll talk about that later too, where they get low-level lead exposure. So the lead water crisis that we heard about in 2016 in Flint, Michigan, this is not new, all right? This is something that has been around for quite a long time. I don't know if you remember, just about the same time into January in 2004, this was a really big deal in Washington, D.C., where there was a big campaign. They found elevated lead levels in, you know, thousands of homes in the district. And there was a big campaign, including pediatricians, the local chapter of the AAP then, about, you know, elevated lead levels in water. And then most recently in New Jersey, in Newark, the persistent crisis of lead in water. So again, how does that become relevant in Washington? Well, the elevated lead levels in water in school And that's what I heard when I came to interview, because there's old fixtures on the pipes, okay? And again, the new housing stock, we don't need to worry about this, but we do have older housing stock and fixtures, in our state. New sources, and again, I put new in quotation because these really aren't new. They've been around, but we've realized that they contain lead. Pottery and ceramics with glazes, imported from other countries, primarily Mexico, Central America. The vinyl mini blinds, that was a big deal in the mid-90s. Lead shot and BBs, okay, you can tell I'm from the South because there's a lot of hunting that goes along, and kids swallow bullets and lead shot. However, I will bring this full circle. We have had 2 calls to the Poison Center in the last week with kids eating lead shot, okay, in our state, okay? So again, I try to not put my blinders on, but there's leaded BBs that are old, and we try and make sure we understand, if lead shot's in them. Certainly with the diverse ethnic population that I absolutely love in this area, in this state, there's a lot of lead though in spices, in imported candies, and then moonshine. Okay, now moonshine, yes, I'm from Alabama most recently, and there was a lot of moonshine. However, we have gotten 2 calls since I've been here about moonshine in Washington State, and concern about how do they make it with radiators, and there's lead that lines the radiators, okay? So again, it's just awareness about this. We created a fact sheet in conjunction with the Somali Health Coalition and the Department of Health, looking at all different potential lead sources. Certainly surma, cajole, or coal that is painted on the eyes has very high lead content. A lot of traditional remedies. And part of our grant with King County is we have community lead shops where we educate people about sources of lead that they may not be aware of. And then the spices. And I'm going to tell you about all the wonderful resources we have in our state. However, there are other lead sources. We need to be cognizant. We have such a wonderful, diverse population in our state. But if you have children adopted from or who have lived in or traveled to another country, you need to think about lead. Or if you have children less than 9 to 12 months, you need to consider prenatal transmission, depending if the time since immigration of countries and perhaps the mother was exposed to lead. We see a lot of this, and there's been a lot of published reports from Mexico and other very, very high industrialized third world countries where there's so much pollution in the air, like China, and they get passive inhalation from lead because lead's still in the gasoline of cars. Also, there is lead transfer in breast milk. Take-home lead exposures, this is also, sometimes people aren't aware, stained glass making, ceramic workers, construction workers. Over in Bremerton, where the shipyards are, they paint, there's still lead in paint that they use on ships. And so again, there's a lot more education now, but workers are supposed to take their clothes off before they come home. And so there's not secondary transmission of lead, because you throw your clothes in the laundry room or on the floor when you first get in, and then kids play and they get lead on their hand, etc. Secondary transmission. We used to call this yuppie lead in Boston because people would renovate these 100-year-old homes without themselves, without taking precautions. And I have to admit, my younger sister started doing that herself, and then she quit when her oldest got exposed to lead and had an elevated lead level. Well, now he just got his PhD. And, but again, I think there's other factors there. But she wasn't aware. This was back in the 90s. And I think we're, much better in our communication about this because of all of us in healthcare. But lead smelters and refiners, polyvinyl chloride, that's just stuff that I have to know for my test, these less important ones. So, clinical toxicity. This is a advertisement from the late 90s that I think is still relevant. The silent menace. Well, why do people not? Well, my child looks fine. Why do I need a lead test in my child? And we'll talk about, the fact that most lead toxicity in U.S. children is subclinical. Although, again, I see kids after the fact if they've needed chelation, and then it's very interesting that some of the caregivers or parents report, oh, wow, there's a difference now. And sometimes it's recognized retrospectively because some of the subtle behavioral changes, sleeping pattern changes, etc. I really like this visual. This came from the WHO monograph on childhood lead poisoning. But for old people like me, we used to have this graph that the CDC published on when you started seeing different toxic effects of lead based on the blood level, the nerve conduction velocity, etc. And this has changed a lot in the last 20 years with the emergence of more conclusive evidence about the developmental toxicity occurring even at levels as low as 5 micrograms per deciliter. Certainly, we've known for a long time about lead's potential effects on hearing, delayed puberty, and then the encephalopathy, as well as the anemia, etc. And I don't hold strongly to these absolute levels because I think it depends on the chronicity of exposure that you can actually see most of these effects. So what has changed in the last 20 years? This is a great monograph that the National Toxicology Program published in 2012, so almost 8 years ago. But looking at low-level lead poisoning, again, not levels of 300. My very first case I had as a fellow in Boston was a 3-year-old who had a child of lead level of 357 and was quite encephalopathic. But certainly we have more evidence about the neurologic effects, and that's where the research really has focused on. We've known for quite a... Sorry about that. We've known for quite a bit about the hematologic and renal effects, the endocrine effects, the cardiovascular and reproductive effects we've known about for a little bit longer, but it's really the neurologic ones that a lot of research has focused on. I show you this slide because I think it's really important to understand when you get a lead level in the blood, understanding a little bit about the kinetics. So what happens when lead gets into the body? And it's a little bit different in the pregnant woman, and it's a little bit different in adults our age. In children, the reason I show this is because there's a dynamic movement, especially in children under 6 years of age. So lead is primarily, when it's absorbed either via the GI tract or directly into the lungs, goes into the red blood cells. Very little of it goes into the plasma. That's why we do capillary blood lead, venous blood lead. We don't spin the blood down and look at the plasma or serum. And then there's this dynamic movement between the soft tissues, the brain and the liver, as well as the bone. You and I, the majority of it is going to go to our bones and sit there, all right? But remember that children are growing, so this equilibrium, is much more dynamic, as well as this equilibrium between the brain and the liver. And this is where the concern comes. For anybody who trained when I did in the late 80s, you remember this graph. This is on the pediatrics boards, or it used to be. I still take the general peds exam, but lead affects, multiple enzymes in the synthesis of hemoglobin. Okay, so when I was a resident, we used to screen for lead looking at protoporphyrin. We don't do that anymore because we can get a lead level now. But lead causes anemia, and it actually causes anemia by 6 different mechanisms. However, usually when a child is anemic, unless they have markedly high lead levels, it's usually concomitant iron deficiency anemia because of the same risk factors for iron deficiency we see in children with elevated lead levels. So just to be aware about that. We know that lead impedes vitamin D metabolism via its effects actually on the kidneys and the alpha-25 hydroxy vitamin D synthesis. We also know, and I don't have time to go into all the literature, that it can delay puberty, including menarche, breast development. It can depress the secretion of growth hormone and insulin growth factor, resulting in postnatal growth. And a lot of studies that were done in Australia, the Port Paris study that's been going on for ages, actually looked at a lot of lead's effects on growth and height velocity, its effect on the velocity of the height. Certainly in adults, what we worry about is hypertension, which is renal mediated, and there have been lots and lots and lots of studies of adults working in lead smelters and looking at the development of hypertension, as well as lead's effect on the reproductive system. In males, it affects sperm count and function. We have some evidence that probably are directly related in terms of pregnancy outcomes, although the conclusion about lead's true effect on infertility, I don't think we have the absolute definitive answer yet. The carcinogenicity, we don't know. That's a very, very hard thing to study. So symptomatic children with lead poisoning, as I alluded to, acute encephalopathy, I haven't seen since the early 90s. That child I had was acutely encephalopathic, was in the ICU, intubated with increased intracranial pressure, coma, seizures, etc. But I think it's this subencephalopathic symptomatic plumbism, that's like the term you see a lot. These behavioral changes, which could be very subtle, constipation, we see a lot, but kids get constipated all the time. So, not every kid with constipation has lead poisoning. Sleep disturbances, as you guys all know, and you do general pediatrics. I don't do general pediatrics in my everyday practice, but you see these all the time, and this doesn't mean that these kids all have lead poisoning. But many times, as I alluded to, if a kid has a really high lead level and is subsequently either chelated or hopefully the exposure has ceased and the lead level goes down, some of these symptoms may get better or go away, and so it's recognized in hindsight. Lead as a neurotoxin. As I mentioned several times, I think there is a lot of evidence out there. Some of it's better than others, but numerous studies have indicated that blood lead levels above 10 are associated with decreases in neurocognitive functioning in children. And I don't have time to go over all of this evidence, but again, when I was training and then in the late 90s, early 2000s, we started to see a lot of this evidence come out with, I think, some fairly good studies. I think there's cumulative evidence to suggest that blood leads less than 10 and then even less than 5 are associated with adverse neurocognition and intellectual ability. I think some of the studies are better than others because you have to control for confounding variables when you're looking at neurocognitive development and intelligence. And these are really tough studies to do. And I applaud a lot of these investigators who have done them But I think you have to read through them very, very carefully. And certainly those monographs that I referenced, the WHO and the National Toxicology Program monograph, there were panels of experts that looked very, very carefully at these studies and the quality of the studies. And so then about 15 years ago, this whole idea, well, is there a threshold for toxicity? And in the environmental toxicology world, we call these thresholds NOEL, no observed adverse effect level, versus a non-threshold model. And I'll talk to you about that, meaning any exposure or any level can be toxic. And again, a lot of toxicologists talk about this model of threshold when we talk about carcinogens. That's kind of where it bore out of. Lead and its associations. I like this slide because when we have lead exposure, what do we know? We know that it can decrease IQ. And again, these are studies that looked at populations, okay? And we know it can decrease school performance. Back in the 70s in Boston, there were really a bunch of great lead gurus that I had really the privilege of meeting that looked at dentin levels, levels of lead in teeth, and then they followed these kids, until they were young adults. And they published a lot of these papers looking at antisocial behavior, delinquency, incarceration. And then, a lot of the most recent research has looked at behavioral problems, attention-related problems. I'm just going to highlight a couple of these studies. In 2008, so about 11, 12 years ago, Jusko et al. Published a study. And why I like this study is because it followed kids, up until 6 years of age. And it really was a very, I thought, more comprehensive study. And they adjusted for confounding variables, for maternal IQ, for psychosocial risk factors, and they looked at lifetime averages of blood lead and found that there was an inverse association with the degree of lead in blood and performance IQ scores. So a negative association. So the higher the lead level, the lower the IQ, etc., and looking at these other confounding variables. I put these two graphs on. This came from a paper in 2005 where they actually put together several studies, including 3 studies that were not United States studies. Porphyry, I mentioned, that's the big study that's still ongoing in Australia, Mexico, as well as Yugoslavia. And again, my point in this was to show that the majority of these studies show that as the lead level increases, the IQ decreases. Now, just note on the one graph, where you're starting from varies on what population that you're studying. They also published this figure looking, again, taking all. This was a meta-analysis and then developing this log linear model, looking at IQ and concurrent blood level. And again, there appears to be I believe this, a negative association. But this was really interesting. When you look at lead levels less than 10, sort of the degree of negativity, so the slope of the line appeared to be much steeper. And this provided some of the evidence for when the CDC changed their recommendations. This is a study from Detroit Public Schools looking at early childhood lead exposure and academic achievement. And what they did is they predicted the probabilities of scoring less than proficient on 3 tests of their own statewide educational assessment program test as a function of blood lead level. And again, the take-home point is math, science, and reading, all the curves look similar. So as the blood lead level increased, the predicted probability of scoring less than proficient increase, all right? But where do you notice the slope is highest? It's really down in the lower range. Also, we know that the fetal brain has a much increased susceptibility to lead. Fetal hemoglobin has a much greater affinity for lead than hemoglobin A. And as we all know, brain and CNS development occur most dynamically from fetal gestation through the second year of life. So that's why maternal exposure to lead, and in many, many states, it's actually mandated that all pregnant mothers actually get a lead level as part of their screening labs during pregnancy. And we know that there's vulnerability of developing organ systems to, a lot of environmental toxicants, but the brain being the primary one, and it can vary widely over the course of pregnancy. So is there a blood lead level threshold? So when there's no threshold, that really means there's no safe level. And I give you just one example of a graph that was published. This was the big Canfield study that was done looking at intellectual impairment in children with blood lead concentrations below 10. And again, you can see a similar steeper slope here compared to even out here, which was very surprising to me because I didn't really expect that we would see that. Because initially, kids I was seeing during my training back in the early, were kids, we didn't have any, we had our own lead clinic in Boston, at the Children's Hospital. They couldn't even get in the lead clinic unless they had a lead, over 20 or sometimes over 30. So I was seeing kids with lead levels of 50, 60, 70, 80, 90, 100, 110. And certainly that has all shifted. We do have evidence, and a lot of these studies are delineated in the NTP monograph that I mentioned, about decreases in IQ, academic achievements, and specific cognitive measures. And again, there's been a lot of studies published looking at the increased incidence of attention deficit, hyperactivity disorder, and other problematic behaviors, aggression, poor impulse control in kids with elevated lead levels. And this graph is a bar graph showing the ADHD diagnosis at age 10 versus blood lead levels at age 1 in boys specifically. And my mentor in Boston actually published some of the first studies looking at ADHD and lead levels. So what's new and why? And it's really not new anymore. In 2012, the CDC lowered the reference level of 10 micrograms per deciliter to an action level of 5. So why did they do that? Okay. It's not because we're going to treat more children with chelating agents, okay? It allows us to pick up children earlier, identify sources of lead exposure, and remove them. Again, I think lead is a great public health model of primary prevention, okay? We're doing a lot of secondary prevention now, but primary prevention. We can identify geographical areas which are at higher risk for exposure. And I'll talk about screening because I think there can be focused screening. I don't think there needs to be universal screening in our state. This again is a graph looking at CDC blood lead surveillance, and it's good. It's good news, all right? So, but we have to look at the number of children tested. Blood lead levels 5 to 9, that's the green. It's gone down based on, but these are only children we test. If you don't test, you don't know, okay? Or if you don't ask for risk factors, you don't know. And then the red line shows lead levels greater than 10. And you can see the inflection point here, occurred in the early 2000s. And so I think actually this is good news. And I think this is public health. This is a success story, all right? Why is it important to screen children in Washington State? If you look at testing rates of Washington State children under 72 months, and look at and compare them to the percent of U.S. children under 72 months, we're testing about 3 to 4% children, okay? Compared to, again, this is low too, about 17 to 18%. Now you're going to say, well, I'm not going to test because I'm never going to find a child with an elevated lead level. Well, I think that can be true if you screen them and ask them if they're at risk, okay? But if you don't screen them and determine if there's risk factors present, you're never going to pick up those children. So what percent of Washington tests come back greater than or equal to 5? Well, it's low. Okay, but these are the kids that you can intervene on, so the next time you test, and we had a perfect example of this about 5 months ago, where that lead level went up. It went up 50 points. Okay, and so I think there's, again, this is a great public health model of where we can intervene and make a difference as healthcare providers. I'm grateful to my partners at the state in the lead program here. This is a heat map looking at blood lead testing rates by county. The darker the color, the percent of children, it's higher that are getting tested. Okay. Now again, look at those counties. There's lower populations. Okay. So again, you have to understand what this map is showing you. Now, when you look at elevated blood lead level rates, this is the distribution of the percent, okay? Now, is this too surprising? I don't think it will be in King County because we have the highest population, but also we have some of the oldest housing stock, and that's what people don't I didn't realize that when I moved here. I've learned a lot. But these are nice heat maps you can find on the DOH website. When you look at elevated blood lead levels by county, again, King County isn't the highest. But again, looking at some of these darker brown areas, a lot of these are rural, so there's less population, but it just gives you a sense. When you look at housing stock by year period, I had no idea. Built before 1950, about 19% in Washington State. About 23% built between 1950 and 70, and about 58% after 1970, so much less likely to have lead paint in the house. So then you say, well, how can I find out where I'm looking at children? I'm not really sure. Well, there is a beautiful interactive map that you can go to on the DOH website. You can hone in on your area, and they calculate a lead exposure risk based on housing stock age as well as poverty level, okay? It's great. You just hone in because you may be in a low risk area where you're seeing your patients from, okay? This is really, really a very, very nice tool that you can go to. Don't forget, we have a high population of refugee children, and they are disproportionately affected. That's how we got involved with the Somali health group here in King County, because they looked at lead levels of kids. They are required to get a lead level when they come here, and looking at lead levels of these refugee children, the percent that have elevated blood lead levels is about 24%. This is data from 2015 to 2017. So again, this again is something you need to think about. Who do I have to screen in the state of Washington? Children on Medicaid are required to have a blood lead screen at 12 and 24 months. That's a federal mandate. All refugees ages 6 months to 16 years on arrival to the U.S. Should have a lead screen. Again, here we have some great clinics in King County where they set these kids up and they follow these kids, not just for lead, but for the other medical screening things. And usually get a follow-up 3 to 6 months post-resettlement, depending on what the initial lead level is. And I found this statistic very interesting. About 50% of the refugee children from Afghanistan in our state have a blood lead level greater than or equal to 5 when they come here. And it's kind of interesting to think of why that is. And probably the ammunition, where they were living, the lead in the air, inhalation. I don't know. We're not sure, but just interesting to think about. We have some incredible resources in our state from multiple organizations. Washington State published a great resource a couple years ago. It's all online. It's all downloadable, because I'm still a paper person, but you don't have to be, where they talk about the targeted screening approach, you know, the purpose of that. It provides opportunity for intervention to reduce the exposure as soon as possible and prevent higher blood lead levels. And again, I believe you have going to have access to my slides that have all these resources on them. Why screen? Also, earlier neurodevelopmental interventions. Lead exposure is really not reversible. But exposure does not equal damage. I gave you my nephew as an example. Cognitive and behavioral development is, you know, you guys know this, is so positively influenced by nurturing in the home environment, in the daycare environment, in the school environment. And King County has a program now that actually I learned can be extended to other counties outside of King for neurodevelopmental services that is automatic if you identify a child with elevated lead levels. And you don't know what you're getting. That's another important reason to screen or to ask. This was in the Seattle Times, oh gosh, yeah, 2019, yeah, where Amazon vowed safe reforms because they found toxic lead and cadmium in children's products that they were selling on their Amazon website. So learned a lot about Amazon too since I've been here. Risk-based screening. I don't have time to go over all this, but again, it is all laid out in these beautiful documents on the DOH website. You know, you live in or regularly visit a house built before 1950, or does your child visit a house built before 1978 that has recent or ongoing renovations? Again, all of these occupations and hobbies to ask about, consumer products, and then to consider if you have a child with a developmental disability, or if you're within a kilometer of an airport, or if the child has a lot of pica behavior, like many kids with autism do. So again, all these resources are available to you. Laboratories in Washington are required to report any blood lead level greater than 5. If a clinic does point of care testing, those results must be reported too. There's a whole website, and I talked to the providers at Swedish, because again, I'm not in the general pediatric world. You can call, you can email Elizabeth, who heads this program. If you don't know how to do this, they review the results. They'll convey elevated blood levels to local health departments. And again, local health departments are offering a suite of services, including home visits, case managing, etc. Recommendations on what to do. This is why we get called at the Poison Center sometimes, but also you have at your disposal an incredible resource, the Pediatric Environmental Health Specialty Units at UW. It's a federally funded program. Dr. Catherine Carr oversees that. She's a general pediatrician. Outstanding resource that you can call, ask questions. We're always available too, and again, I like doing this, so but if you ever want to talk to me, but the PACU has great resources on their website. How do you target? What do you do when you get an elevated lead level? And there's a whole algorithm and table I think is just wonderful. I don't have time to go through all of these, but paint hazard measures, about what you tell caregivers and parents, if there's old paint in the house, and how you clean up. You don't want to be using vacuums on lead dust because that just spreads it. There's certain ways to clean clean dust. And the local health department and the DOH, they are happy to guide you. Or if somebody comes out to your patient's home, they go through all of this, where the caregiver and or the parent. And so again, I don't have time to go over all of these, but the grant we have with King County, we are going out in the communities and educating people about sources, health remedies, what to do to prevent your child from getting exposed. This is the PACU document they have for healthcare providers. This is a wonderful document that Dr. Carr and her colleagues have developed. If the lead level is this, what do you do? If the lead level is this, what do you do? If it's this, when do I repeat the lead level? Okay, it's all online. It's great, 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 great. They have some great fact sheets on traditional sources of lead that you can download, give to your patients. We also have those. If you want to call us, they're on our website. We have rack cards that we developed in several different languages. If you have a high ethnically diverse population, we did that with our collaboration with Public Health Seattle, King County. Guidance for waters. If you live in older housing, about running waters, or there's filters specific. You have to look though if they can trap the lead. Most of the newer housing, you don't need to worry about the older pipes, but again, some of the fixtures have lead solder in them. This is the problem with the schools. And then finally, to finish up, if your practice is testing for lead, and I know when I gave this talk to some of the Swedish healthcare providers at Issaquah and the quality assurance leaders, you guys already knew about this. The CDC put together this great video on how to test children for lead with maximum accuracy, because you have to make sure you clean the finger when you're doing the finger stick, because you don't want it contaminated, okay? So that second case I gave you, when the repeat venous lead was done, it was 6, okay? But it was 92 on the finger stick because the finger probably wasn't adequately clean. But this video is wonderful, and it has a nurse and a phlebotomist, and it's really, really kind of cute and very engaging on, some of the rules about you shouldn't use certain paper towels to clean the finger, etc. So it's well worth it for your nurse assistants or your phlebotomist or your nurses, and I actually learned a lot reading it. So again, lots and lots and lots of resources are available, and if you have any questions, please feel free to contact me or the Pediatric Environmental Health Unit. We all try, or the Department of Health, either locally or statewide. We all work together. And so I think that as healthcare providers, we can make a real difference. So thank you.